Okay, so I've been assigned to discuss skeletal trauma, casting, and traction. So I just made a brief PowerPoint presentation based on what I thought was the most important to go over in 5 minutes. So we'll start with skeletal trauma. The human skeleton, a normal skeleton, contains a total of 206 bones. There are long bones, which are hard, dense, provide strength, structure, and mobility. Your short bones provide support, and they have minimal to no movement. The flat bones provide extensive protection and allow for muscular attachment, like the bones in your face. Sesamoid bones are the little small bones that move independently of one another, and they are located in the hands and feet primarily. And then there are also irregular bones, which are located mostly in the vertebrae, and they provide protection of the nervous tissue. So a fracture is a break in the bone secondary to trauma or pathological cause. Some of those pathological causes can include metastatic cancers, osteoporosis, and Paget's disease. Trauma is, however, the most common fracture factor. There are several different types of fractures. The first one I will go over is a closed or simple fracture, which is the kind of fracture that does not break through the skin surface, but it could happen, like, say your leg got crushed and the bone broke inside of the leg and the skin did not open. That would be an example of a closed fracture. An open fracture, also known as a compound fracture, causes tissue injury by disrupting the integrity of the tissue. So in that case, the bone could pop through the skin, therefore opening a portal for infection. A complete fracture involves the entire bone, and it's divided into two separated parts. An incomplete fracture does not break through the entire bone, and it might just be cracked or fragmented. A displaced fracture contains bone fragments out of alignment. Non-displaced contains the fragments, but they're still properly aligned. A compression fracture occurs from a loading force on a callous bone, and that happens mostly with older clients. And then there's the spiral fracture, which occurs from a twisting motion, and that's usually indicative of abuse in most clients. Traction is the application of a pulling force to a part of the body to provide reduction, alignment, and rest. Countertraction uses the patient's body. So why are we going to use traction? Because it promotes healing and decreases muscle spasms and pain. It also immobilizes the extremity to allow for proper healing and non-disruption. It's going to prevent, possibly correct, any deformities that were caused, and it's going to allow your joints to have some resting time. The most common type of skin traction is Buck's traction. It's a skin traction that is used temporarily to immobilize a fracture of the hip or femur until surgery is ready to be performed. It can also relieve the muscle spasms in the lower back or realign the vertebrae. In this case, the leg is wrapped in an elastic bandage, and traction is applied through weights attached to a spreader that is below the feet at the end of the bed, and the pull is going to pull towards the end of the bed. You're going to want to ensure skin integrity by checking on your patient's skin frequently. You want to tell them to avoid pressure on their heels or their bony prominences anywhere. Because they're going to be in bed, you want to keep moving them around to prevent pressure sores. You're going to keep that head of the bed flat or the foot of the bed elevated to maintain countertraction with the client's weight. Skeletal traction is a traction applied mechanically to the bone by use of pins, wires, or tongs for fractures of the femur, tibia, and spine. Redness, warmth, and serosang drainage are expected, and you should never touch the weights unless you're ordered, because it could harm the patient. A priority nursing assessment is your neuro assessment, and you're going to want to check pin sites frequently and assess the skin integrity as well. Okay, so you can have internal fixation or external fixation. It's kind of self-explanatory, but the internal, everything's fixated internally, so you're not going to be able to see anything on the outside besides whatever swelling or redness is there. And external fixation is where the pins and pulleys are attached to the outside of the skin, and they use a brace or cast. Casting. There are basically two types. There's a wet plaster cast, which is going to take 24 to 72 hours to dry. And when you're putting that on the patient, you should be using the palms of your hands so that you don't manipulate the material. Do not apply heat when drying because it could heat up too much and actually burn the patient's skin. You should use isometric exercises to prevent atrophy. And a window may be used if the patient has to be drained. So that's like a little flap that they'll open up. There's also a synthetic type of cast, which only takes 20 minutes to dry, but it's less common. And then finally, I've just got some nursing considerations for those in a cast after all of this has been done. We're going to turn the casted extremity every 1 to 2 hours to allow for air circulation and promote for drying of the cast. A hairdryer can be used, but it needs to be on the cool setting. We're going to want to assess for infection, circulation, and skin integrity. Like I said, use the palms of your hands to manipulate a wet or damp cast, and we are going to advise that patient to elevate that affected extremity. So that's all I have for my presentation here, and I hope you learned something because